Welcome to Chapter 6, The Human Body. As you can imagine, an important part of being an emergency medical technician is being able to um, recognize what is normal function and anatomically of the human body is so that you know what's abnormal in instances of disease processes or in trauma. So when we talk about the human body, we're going to talk about the different systems, how they operate together, how the cardiovascular system um, affects the uh, respiratory system and vice versa. And then we're also going to talk about anatomy and pathophysiology. So if you think of anatomy as form and pathophysiology as function, and oftentimes form is something in the body is made the way that it is because of its function. Like if you think of the heart, the left side of the heart, the shape of it and the way it's angulated off to the left, much thicker walls. That's because the lower left chamber of the heart, left ventricle, needs to pump blood to the entire body, so it's a much thicker muscle. So kind of form kind of meets function with that. So we're focusing on the anatomy, physiology, and also the different body systems. So, working knowledge of anatomy is important. Like I said, knowing what's normal will help us know when something's abnormal. We have, like when we talk about trauma, lots of things, acronyms to help us remember. DCAP, BTLS. We speak of deformities, contusions, abrasions, burns, tenderness, laceration, swelling. I kind of like to simplify that too, as far as if anything causes pain or is just deformed in any way, then you can kind of assume that there's some injury in that location or underneath there. And it's really hard to be able to visualize internal injuries, internal bleeding, and so that's why we have to have a high index of suspicion based on damage patterns or what the mechanism was that caused it. But we also have to know what's underlining in the body in that area, what potentially could be injured. So, knowledge of this anatomy also will help us be able to talk to other medical professionals, kind of like we spoke about medical terminology, um, and those who may not understand medical terms, when we can just discuss uh, places of the body, how it's affected, simplify it for them so they kind of understand what's going on. So imagine when we talk about planes of the body, these are imaginary straight lines that divide the body in three main areas. We talked about the midline, the medial line that goes straight through the center of the body. That was just a line. This kind of actually separates it into complete planes. So we have the frontal, the coronal plane divides the body from the front to the back, or the anterior to the posterior. The transverse or the axial plane divides the body from top to bottom, and the sagittal or the lateral plane divides the body from left to right. So here in this diagram, it shows you just how those planes, how they represent. You got the frontal, like we said, plane that separates from the front to the back, the sagittal from the left to the right, and the transverse from top to bottom. And I know they just kind of show this from the shoulders to the knee area, but they run the full length of the body. So the skeletal system is the first system that we'll talk about. It gives us a recognizable human form, gives us our shape, it allows us to move. It takes our muscles, but it's our muscles that are attached to our bones that are able to allow us to move. It protects vital internal organs. If you think about like the rib cage, protects our lungs, it also protects our heart. Um, but if you think about the thing that protects us, oftentimes can be what causes injury. We talk about tension pneumothorax, right? When you get a penetration into that lung, and then that's allowing air to escape inside the thoracic cavity, but outside the lung itself, and it's disrupting that pressure variant. So and it's actually increasing the more pressure that grows outside of that lung space is causing it to get worse. Well, oftentimes what may cause that is a broken rib, right? Or if we think about a vertebrae, when somebody has a spinal cord injury, oftentimes it's actually the vertebrae that will lacerate that spinal cord. So yeah, it's there designed to protect it, but At the same time, if something is a mechanism, force applied to the body, is strong enough to um, cause that bone or that protective protection to break, it can cause lots of damage as well. So when we think of the skeletal system, we think of the bones, right? They give us form. They also help produce red blood cells, and there's other things that they do as far as helping out processes of the body. Ligaments, they help connect our bones together, and tendons help and connect the muscles to our bones, and then that cartilage that helps definitely at the outside of bones, and definitely areas where bones meet at ends to cause a joint so that it's able to move. The axial skeleton is the foundation to which the arms, legs are attached. It includes the skull, the spinal column, and the thorax. We'll go into a little further detail. So the skull is made up, the cranium itself is made up of 4 bones. The face is made up of 14 bones, so a lot of separate bones you can see from this picture. So those main bones that we think of the cranium, we got that frontal bone of the in the front area, as you'd imagine, temporal bone, side of the temples, the parietal bone up top, and then we have to look at this underneath bone to really see back behind us. We have that occipital bone, right? And those bones, they make up what we call the cranial vault, which the brain sits inside. It's kind of important to recognize once the body develops, the skull develops, and those bone plates fuse together after infancy, when we often call it a soft spot up there. But once that fuses together, we create that cranial vault inside there. And so the problem with that, again, it's there to protect the brain, and it does a fairly good job most of the time. But if there's any type of bleed that happens inside of there, there's no room for that pressure to go. So it starts putting pressure upon the brain, and can cause lots of different deficits and problems that we see, that we might catch in a neurological exam that we'll talk about later. And then the bones of the face, another thing to have mentioned is a possible Lefort fracture, and in things like this, things can be very distracting. These type of injuries when the face bones actually break, and it kind of we lose that shape of the face. But again, it kind of goes back to the basics with anything of this: airway, breathing, circulation, right? So, even when you get a distracting injury like that, think airway first, then breathing, and then how's their circulation. We talked about before in class, teeth. You see missing teeth, your question should be, say, hey, could that be a possible foreign body airway obstruction? Is that normal? Did they have missing teeth before? Over here, you'll see this hole that the spinal cord goes through, the foramen magnum. And that's kind of note too when we talk about that intracranial pressure. You can actually have that brain be pushed down through that port. And the cranial vault, it's very important to recognize the fact that it doesn't allow very well for that increased pressure. And so that's a real true emergency, and should be kind of what we're thinking about anytime patient falls, has a head injury. We see problems with the eyes, they're on blood thinning medications. That's kind of what we're concerned about. So the spinal column, it's composed of 33 bones, vertebrae, divided into 5 sections. We have the cervical, which is the top, the thoracic, which is the one right below it, right where the lungs and area is, lumbar, sacrum, and coccyx, which is fused together. And a way to remember the number of these is, I like to associate a lot of things with food. So the beginning one is breakfast at 7, right? Cervical 7 vertebrae. Lunch at 12. Then dinner at 5. I always have seconds, so 5 again. And then just remember that there's 4 fused vertebrae for the coccyx. So 7, 12, 5, 5, and 4. It's fairly important of note to realize kind of where, if you have a spinal injury, general rule of thumb is anything lower than that mark of that injury, they're going to lose sensation, motor function. And then when we get higher up, the kind of worse that it gets. You know, if we get to a cervical injury, we may actually even lose the ability for the diaphragm, and that'd be a patient that you would definitely have to be ventilating with a bag valve, mask, BVM ventilations, because their diaphragm just simply isn't working because it's not talking anymore with their central nervous system. So where the higher up on the body or on the vertebrae or on the spinal column, the injury, kind of the worst off you can expect the patient to be. So the thorax is formed by 12 thoracic vertebrae and 12 pairs of ribs. Thoracic cavity contains the heart, lungs, esophagus, and the great vessels. So the great vessels would be just the major, or the vessels that are carrying the most amount of blood, either the superior inferior vena cava that are returning blood to the heart, or that aorta that's carrying all the blood from that left atrium before it starts to kind of shoot off into the smaller, which are still major, but arteries smaller than the aorta, to feed the rest of the body. And kind of some landmarks to note here would be the sternal notch there at the top. So the supra on top of, bringing some medical terminology here, suprasternal notch up top there, and then you have the sternum, just medial all the way down, and then the xiphoid process would be that bony extension inferior to that on the bottom of the sternum. And that's something to note because let's say someone's doing CPR, we definitely want to avoid that xiphoid process because that's actually directly above the diaphragm. And so if we were to lacerate the diaphragm, it wouldn't be able to work in order to help ventilations, right? So that would be a very, very bad thing to happen. That's why we want to stay, we usually say about nipple line, but above that xiphoid process on the sternum there. Also to note here are how you can kind of count the ribs by starting right where the sternal notch is there, and you're about at the first rib, and you can just start to count them as you feel them down, and to recognize once you get to the sixth rib, then we start to get these ribs that articulate. So rib 7, 8, 9, 10 on there, they articulate or touch the rib next to it. They kind of call those false ribs because they don't directly connect to the sternum there, but they connect to the rib above them that connects to the sternum. And then you have the floating ribs down there, 11, 12 at the very bottom. So it's important to know these again. So when somebody's in pain, has had some injury on that side, motor vehicle accident, fell, blunt force trauma, we know what's normal. Another thing to be able to do is compare it to the other side, right? Now we're going to talk about the appendicular skeleton. This would be the extremities, right? The arms, legs, their connection points at the pelvis. Includes joints, upper extremities, pelvis, and the lower extremities. So a joint occurs when bones come in contact. One bone meets another bone, it's going to make a joint. There's a couple different types of joints, right? We have one of the shoulder, that ball and socket joint. The hinge joint allows for flexion extension when we think about the knees there. This is two kind of pictures just showing the ball and socket versus the hinge joint of the knee. Upper extremity extends from shoulder girdle to fingertips, composed of the arms, forearms, hands, and fingers. And then kind of fast forwarding a little bit to talk about splinting. The rule of splinting when you're trying to splint a joint or a bone, whether it be a long bone or a short bone. Long bone being like the humerus, or the femur, right? And then the shorter bones being like the radius or the ulna, would be that you want to splint above and below that bone or joint. And the reason being because that bone or joint that has been compromised, possibly broken, maybe just sprained, but definitely injured and causing pain, the joints above and below it, if they're whether it be a bone or joint, if they're manipulated, they're going to cause a movement on that. And you can kind of see that if you hold your arm and then kind of open and close your hand even, or definitely turn your wrist at all. So that's why we want to splint above and below. And then if it's an extremity, upper extremity, we're actually even going to put that in a sling and sloth and secure that to the side so that they're not able to move that at all. Not only is it going to cause pain, but those bone ends could cause further injuries and tear up and just make it a harder rehabilitation, or even put them in a potentially life threatening event if they're continually losing blood because of that movement of it. It's not able to form a clot. So we're talking about the shoulder girdle. There's three bones that articulate or come together. You have the clavicle, which is that bone kind of there in front, the scapula behind in the shoulder, and then the humerus. Same idea. So you see how, let's say somebody has a broken clavicle, which is a fairly common injury. We don't, if they were to move that arm, that humerus at all, or that scapula, then that would cause movement of that clavicle. More pain, could cause more damage, more bleeding. So that's why we're going to immobilize that altogether. That's why immobilization is so important. It's not just for the pain, but it can help prevent further injury. So the arm, the humerus, is the supporting bone. The forearm consists of the radius and the ulna, and if you can think of the radial pulse, right, is on the thumb side, and the radius rotates around the ulna. So the radius is on that thumb side, and then the ulna is on that other side there. And then when we talk about the wrist and the hand, is another representation of ball and socket joint. The principal bones here would be the carpals, the metacarpals, and the phalanges, right? And then whether it's on your hands or your feet, you'll notice those smaller bones of those digits we call phalanges. The difference between the hands and the feet: hands are carpals and metacarpals, and then you'll see the feet are tarsals and metatarsals. You step in tar, right? So that's kind of a way to split those up in your head. And here they decided to go with identifying each of those digits as the thumb, the index, long, ring, and small finger. I myself, I prefer identifying with number 1, 2, 3, 4, and 5. When you look at the hand in this regard, that they have phalanges, right? Maybe the number of joints is the only thing that's different between a thumb and, let's say, an index finger. So on that sense, I give them just a numerical 1, 2, 3, 4, 5. So my first finger on my right hand would be my thumb on my right hand. Granted, you can identify these as the thumb, index, long, ring, and small. Another reason why I may say, hey, you might want to think about identifying them as the numerically is somebody may have some tingling radiating down their right arm that extends to their to their thumb, index, and long finger. So it's easier just to document and say, yeah, they have some pain on their right arm, that or burning sensation, whatever it is, that radiates down to their first, second, and third fingers. So that's just kind of anecdotally why I've switched over, or kind of assumed identifying them that way. So the pelvis, closed bony ring, consists of three bones: the sacrum, two pelvic bones. Each pelvic bone is formed by a fusion of the ilium, ischium, and pubis. Here we'll see the representation there, right? Posteriorly, the ilium, we have that kind of long wing bone. The iliac crest up there is a good landmark that we use lots of times to find the hips there. And as we're kind of trying to establish the integrity of the pelvis. And the pubis bones are joined by the sacrum. Down there towards the backside. Anteriorly in the front, the pubic symphysis is where the right and left pubis are joined. And then something to note here, you see the ligaments where this descending aorta and inferior vena cava come across right there. That can be a very that could actually lacerate that artery and that major vein if there's some sort of trauma there to the pelvis. And a lot of blood can fit inside this pelvic region without maybe you even seeing a sign of it on the outside, except for the fact that there's going to be pain, right? You may not see bruising or anything, especially if it's immediately after the accident, but up to, a liter or more blood can be bleeding out there internally before you may see an outward sign. So what does this mean to us as EMTs? It means that when there's a significant mechanism of injury being a force that's applied onto the body there, we have to be highly suspicious of internal injuries, right? Especially if it's put next to the fact that there's pain there, or range of motion causes further pain or discomfort or deformity in these instances. So the lower extremities, main parts are the thigh, the leg, and the foot. The femur or the thigh bone is the longest bone in the body. It connects into the acetabulum pelvic girdle by a ball and socket joint. The greater and lesser trochanter are where the major muscles of the thigh connect to the femur. There's your quadriceps sitting on your thigh is extremely strong. That's why we'll bring in and talk about if somebody were to have a mid-shaft isolated femur fracture. So basically, that long bone, that femur, has become broken. Kind of somewhere in that mid shaft there, not all the way at the top of the ball or not towards the knee joint. And anything distally to that, knee, ankle, foot, is all intact, and their pelvis is still intact. What we're able to do to relieve some pain because of the quadricep muscles being so strong and tight, oftentimes once that bone breaks, those muscles contract and shrink down, and those bone ends get sharp bone ends come in contact and kind of cut each other at their side, and that whole leg shrinks up, and it causes an extreme amount of pain. It can cause more tearing, more bleeding, more trauma. So what we could do in that situation is actually apply traction to that, first usually manually, and we go until there's the devices that they have for these traction splints, they have calculations on them, but generally, good rule of thumb is you'll start with the manual traction and apply it until you relieve pain, and then you just meet that resistance with the device. And there's a few different ones out there, and we'll show you them, but basically what you're doing is you're just trying to separate those bone ends and potentially bring it kind of back in line, but you're going to still maintain that traction, and it'll reduce a lot of the pain there, and then hopefully probably prevent some further injury. And then another thing to note is the femur being the longest bone in the body, and extremely strong bone as well. If there is a mechanism, force applied to the body, that's all that really the mechanism of injury, that was enough to compromise or break the femur, think about that force, and if it was applied to any other part of the body, and think multi-systems trauma, then there may be other injuries elsewhere, injuries that might be more life-threatening, but this injury, just as a result of how it manifests itself with those bone ends that stick to each other and cause an excruciating amount of pain, that's what we call a distracting injury, where they may have a broken rib that's actually cut into their lungs, because the same force that broke that femur, if it was applied, it could cause a break somewhere else, right? Or even to their spine. So that might be a patient that, even though they're not complaining of spinal injury midline on their cervical, thoracic, or even lumbar spine, you may consider putting them in full C-spine or some spinal motion restriction, just because of the fact of the mechanism, right? And because of that, if that bone were to break, because of that mechanism, it's a lot of force applied to the body. The way that I kind of think of that is, unless it's isolated, right? They were just hit right here in the leg from a football player that hit them there, or that they realize that if they have an injury anywhere else, even if it's just a cut, on the left side, let's say they fell off a ladder and they have that injury on their leg, and then they have maybe a deformity or cut somewhere on the other side of the body, well, anywhere in between that also had that same force applied. So we have to have a high index of suspicion for these injuries, because they may be more life-threatening. We'll talk more about that when we talk about the thoracic region. So the knee connects the upper leg to the lower leg. The kneecap is the patella, and you can dislocate that patella or kneecap, right? So, but again, it's not our job to diagnose. But so anytime we see a gross deformity of that joint, then we could just call it as such, right? And we try to get it in the position of function, right? That would be not too flexed, and not too straightened, but kind of generally in the middle there to apply the least amount of strain. We want to get things back to that position and splint them in place, or splint them there. If we're unable to do that, then we'll have to splint in place, right? When we get to splinting, there's, you know, not everything is going to be able to be splinted the same way every time, but just the general rules of thumb that we talked about, right? You want to check for that circulation, sensation, and motor function before you splint. You want to try to get it back in line or in the position of function, and then splint it and then immobilize it, and then check circulation, sensation, and motor function afterwards, and be splinting above and below the joint or the bone that is become compromised. That's the general rule of thumb. So moving on to the lower extremity, of the lower leg, we have the tibia, or the shin bone, which is the anterior part of the leg, and the fibula is the lateral side of the leg. And oftentimes, if one's broken, then the other will be broken as well. A lot of times it'll have a tib-fib fracture. The ankle is a hinge joint, allows for flexion and extension of that foot. So here's the foot, contains 7 tarsals. See, we had the carpals of the hands. These are tarsals of the feet. You step in tar. And metatarsals form substance of the foot. Toes are formed by phalanges. So the phalanges are the same, right? Once we get to those digits, they're essentially called the same thing. So the skeletal system physiology, what does it do? The skeletal system gives the body its shape. It protects fragile organs, but it can also damage them, right? We have to have that index of suspicion there. It allows for movement. It stores calcium, helps create blood cells. So there's a lot of importance that the skeletal system does. Instead of just, obviously we see, yeah, it gives the body its shape, but there's other things it does as well. So the musculoskeletal system anatomy. Musculoskeletal system provides form, upright posture, movement, protection of vital internal organs. And then we have 3 types of muscles. We have the skeletal or voluntary muscles. Think about anything you can move, right? Your arm, I'm going to flex it up, I'm going to move it down, I'm going to abduct it up, adduction down back to my side. That would be a voluntary muscle. Smooth muscles would be things like in our digestive tract that we're not able to control, right? Those would be those smooth muscles. And then cardiac muscles, they get their whole own section. Cardiac muscles are fairly fascinating in the fact that each individual cell of that muscle can create its own electrical impulse, or it can receive its own electrical impulse and send it. So it can do some pretty amazing things. We'll get into a few of them at this level at EMT, but just realize when we're classifying types of muscles, we have the 3 different types: the skeletal, smooth, and cardiac. So there are now we're going to break down into the different types of muscles that they have. And names for them. You can see on the deep and superficial kind of have different sides and different layerings of this. Some muscles I'm sure that you'd be fairly used to, deltoid, trapezius, those kind of trapezius shaped muscles on the top of the neck and shoulders, triceps. And then some are going to be a little different, right? That we're not so used to, like the rectus abdominis. We just kind of call those abdominal muscles, right? And so this is the time that I'm going to say, if you call them abdominal muscles, that's fine, right? You don't have to call them rectus abdominis. Just realize that there may be a different name for it. So kind of review this and refer to the muscles that you feel, comfortable with. I'm not going to ask you to refer to the abdominal muscles if someone has pain there as rectus abdominis, because honestly most people will just think of them as abs, right, or abdominal muscles. So for our line of work and what we deal with, that's just fine. But if you haven't been kind of learned any of the basic muscle groups, then maybe take a second to realize where the deltoid is, trapezius, triceps, and some of these major muscle groups. So the musculoskeletal system physiology. How does the musculoskeletal system move and function? Contraction and relaxation of the system make it possible to move and manipulate the environment. A byproduct of this movement is heat, right? Anytime we're moving, performing work, one byproduct is heat that produces. Another function of muscles is to protect the structures underneath them. They are definitely more forgiving than those more rigid skeletal system, as far as causing damage underneath. Um, but if there is, injury to uh, the muscle itself, then that may be something that they feel more acutely than what's hurting the organ or something that lies beneath. So just be aware of that. Our sensation of pain, the deeper we get in our body, is sometimes changes a little bit, right? We have pretty good sensation of pain in these muscles, where it is in location, but there may be an underlying issue to the organ that's deeper than that we're not feeling in the same way. The respiratory system anatomy, structures of the body that contribute to respiration, the process of breathing. Um, so going kind of from the top there, we have the nasopharynx, right, through the nose that helps bring in air, helps humidify air, um, and then that's the nasal air passage down to the pharynx and the oral pharynx. The mouth, and when we're thinking of it in terms of the respiratory system, is just another path for air to come in. It can either go through the nose or the mouth. And then to the epiglottis. The epiglottis is the cutoff between the upper and lower airway. This is definitely going to be a National Registry type question, so that you understand that. The epiglottis cuts off the trachea if you were to swallow or to shut it down so that you don't um, uh, bring in a foreign body into the trachea there. And then we have the larynx just below that, down to the trachea, which has rigid type rings that brings it down to the carina. Right. Now we're getting into the bronchial tree, and it's kind of like ABC backwards, right? We have carina, then the bronchi are the big major branches, the bronchioles are the smaller ones, and then the alveoli. So CBA, carina, bronchi, bronchioles, alveoli, and then the alveoli are these small sacs with vessels all around them, where that um, external respiration happens. That we're going to go into more depth in a little later. So upper airway, we have the nose, the mouth, which is just an oral cavity, the tongue, jaw, mandible, larynx. It divides the upper and lower airway. So the upper airway, the pharynx, nasopharynx, oropharynx, larynx, trachea, epiglottis, and esophagus. So the lower airway, thyroid cartilage or the Adam's apple, cricoid cartilage immediately between the thyroid cartilage, and then there's the cricothyroid membrane. And this is of note for this landmark. If somebody was going to have to do a cricothyroidotomy, and we do that in the instance of there is maybe a foreign body airway obstruction, maybe too much trauma to the upper airway, but it's impossible to ventilate and it's impossible to intubate. We can't get anything in between there, and as a result, the patient's inevitably going to die. So what we're going to do is we're going to open up that cricoid thyroid membrane and be able to bypass, hopefully, wherever that trauma is or where that foreign body airway obstruction is, and to place a small tube in there in order to allow for ventilation, right? So that's one thing for a landmark. Another one, there may be if you're assisting ALS, assisting a paramedic or a flight crew in an intubation, they may have you place some pressure on that point, especially if somebody's anatomy and their trachea or their upper airway is a little anterior, and it's difficult for them to find it when they're performing an intubation, and that may help align it. So that might be something that they help ask you to do. We'll kind of go over that when we talk about introduction with ALS. And then we have the trachea. It ends at the carina, dividing into right and left bronchi, leading to the bronchioles. Lungs. The two lungs are held in place by the trachea. So when we talk about tracheal deviation, right, we're looking at the trachea. Where should the trachea be? Well, it should sit right midline, right? If it's moving to one side, what's going on? Well, if you think about that the trachea is holding the lungs, then that means that something's going on in the lungs underneath, right? It's a sign of tension pneumothorax. It's a late sign, so hopefully something would be caught on before then. But basically, what that means is, remember, a tension pneumothorax is a hole in the lung, and so it's allowing air to escape. It's still inside that thoracic cavity, and now it's starting to push against the lung. That's when it goes from just a pneumothorax to the tension pneumothorax, is when you have that pressure that's inside of there, and so that side that's affected is not able to oxygenate, and then now it's starting to affect the other side of the lung and not allowing that to oxygenate either. And then what also is in that thoracic cavity? The heart. So your heart is trying to compensate, right? Maybe trying to pump harder and faster and with more force, to allow for the oxygen that it is carrying, that it is able to get, to perfuse the body system. Well, once this pressure inside there is starting to move over, it's not allowing for that heart to fill all the way up with blood, and so you're causing all kinds of problems with oxygenation and problems with perfusion. That's why we talk about it a lot, and it's very important to recognize these. You may say, well, we're not allowed to decompress the chest. Why is it important? Well, remember back when we were talking about EMS systems, right? You may be in a position to say, hey, let the crew that's coming know exactly what you're seeing so that they're ready to go, to minimize that time. Or this may be time to get a flight crew involved. Or maybe it might be in time to, thinking about that ethical thing, let's just get this person in a vehicle and drive them up to the hospital so that someone can decompress this chest, because I recognize that of what's going on here, right? So um, after the trachea, we have the arteries and veins of the lungs, the pulmonary ligaments. The lungs are divided into two lobes. The right lung has the upper, middle, and lower lobes. The left lung has the upper and lower lobes. No middle lobe in the left lung. Could you think why there might not be a lobe there? So yeah, because that's the space that the heart is taking up, more on the left side, left lateral side of your left medial side of your chest, but more on that left side. So there's not that left middle lung. So we can listen to these five different lobes when we are listening to the lungs, but also if you just listen to the top and the bases for our purposes, that'll get you right where you want to be. And kind of on the topic of listening to lungs, really the best place to listen to the lungs is on skin contact with the diaphragm there, or that bell of your stethoscope, but it's also usually on the back, right? Because it's just a easier access, and it's closer to, so you can get a better audible auscultation or hearing of those lungs. So within the lobes are bronchi, bronchioles, and alveoli. This allows for that gas exchange. So the gas exchange works off simple diffusion, right? So basically, to the quick rundown again, and we'll probably discuss it a lot, but just because you have to be able to conceptualize this, is your diaphragm will contract and get smaller and move down, right? And your intercostal muscles, all your muscles in between your ribs, will contract, and that actually expands your chest outwards. So your thoracic cavity decreases in pressure and allows for air to move in, just passively moves in, right? And realize I'm not saying oxygen, I'm just saying air, because it depends on whatever environment you're in, it'll bring that air inside. And then once the air is inside the lungs, hopefully it'll get moved to where these alveolar sacs are, and the oxygen will be richer inside of that air, and the alveolar sacs on the side of the lungs. And then the blood, the red blood cells that carries the oxygen, that meets right up against there, because they have uh, the arterioles that meet up right against the alveoli sacs. It's going to be more oxygen poor because the cells in the body have already used it, but it's going to be higher in CO2, right? Carbon dioxide, which is a byproduct of after your body uses the oxygen and goes through the Krebs cycle to make ATP in order to perform energy, right? So on that side, it's going to have a higher concentration of CO2, lower concentration of oxygen. And then on the lung side, that air is going to have higher concentration of oxygen, lower concentration of CO2. And then through simple diffusion, right, law of the gases, it's just going to equalize. If any of you are familiar with like a cascade system of how you fill up BA bottles in the fire department, same kind of way. One tank has, 1500 psi. This one has 700 psi. You open up both tanks and they're going to equalize, right? And so that means that the blood that came to the lungs that was oxygen poor and rich in CO2 now has more oxygen and less CO2, and it can then go off to the continue on through the uh, pulmonary vein to the left atrium down to the left ventricle to pump oxygenated blood to the rest of the body and the heart. And then the air that was still inside of the lungs is now going to have less oxygen, more CO2, and you'll be able to breathe that off. So that's kind of how that gas exchange happens, right? And it's just through simple diffusion and doesn't take a lot of work to do it, which is important because what we are getting that oxygen for is to go through the Krebs cycle in the cell, create ATP so that you can perform work. So it would be kind of counterintuitive if in order to get the thing that helps us create energy to perform work cost a lot of energy to perform work. And another thing to note that is if somebody is having difficulty breathing, if they're working hard to breathe, something's not right. Right? You need to recognize that. They may not have any other complaint, but that is still a sign of shock, tachypnea, right? They're breathing fast, working hard to breathe, and with no other sign, after a motor vehicle accident or something, they may have adrenaline that's kind of hiding some of this pain. They may be a little bit in shock, and their body could still be compensating, right? So we have to realize that, hey, if everything's functioning normally, they shouldn't be working this hard to breathe, right? So kind of moving on to the lungs, we have the pleura. It's a layer of smooth, glistening tissue that covers each lung and lines the chest cavity. Between the two layers is a small amount of fluid that allows the tissue to glide smoothly. And this is the space that air will seep into when we're talking about a pneumothorax and tension pneumothorax, right? So you have a lining around your thoracic cavity, a lining around your lungs, and in that space there's some fluid. And this is so that when your lungs kind of expand and close and they rub together that it doesn't cause damage, right? So there's a space there. So if there's been compensated in that lung there, compromised, they're not compensated, and then air is leaking out into that pleural space that's in your thoracic cavity but outside your lungs. That is what we're talking about when we're talking about a pneumothorax. And then once we get that pressure that's causing that's just starting to disrupt stuff, we get a tension pneumothorax. And then when it gets so bad that it's actually tracheal deviation is happening, realize on the side it's affected, almost no oxygenation is happening, and on the other side, probably very minimal, even with some effect on the cardiovascular, on the heart, the myocardium, the heart muscle itself. So here's a picture. You see the thyroid cartilage, the cricothyroid, and then in the middle of there, the cricothyroid membrane. Usually we call it when we're doing a cricothyrotomy, which essentially is just making an incision right in this location. They say look for the mountain, come down the mountain and look for the lake, right? That's that location right there, and that's what they'd be looking for if they were trying to perform this procedure. And then you have the trachea, also called the windpipe, and then we have the carina, is where that V is, going into the major bronchi, the smaller bronchioles, and then the alveoli. Muscles of breathing. Diaphragm and intercostal muscles are the primary muscles of breathing. Also involved, you have some neck, cervical muscles, some abdominal muscles. You'll definitely see that abdominal muscles happening in younger kids as well, and then the pectoral muscles. When you see these other external muscles used, though, the neck, abdominal, or pectoral muscles, especially in the neck there, you see some retraction is what we call it. So in that space in the neck above your clavicle, and it's kind of sucking down. Well, that's because the patient is putting a lot of pressure down to force some air into their lungs, right? So that's another sign, right, that they're working hard to breathe, so something isn't right. So respiratory system physiology. The function is to provide a body with oxygen and eliminate carbon dioxide. So again, I know we just talked about it, but it's all going to be repetition with this. You guys really got to have a good concept of it. So we're going to go and do it again. And this brings up about carbon dioxide. So ventilation is the movement of air, right? Oxygenation is getting oxygen from that air into the body. So if somebody has an oxygenation issue, we may be able to solve that by just hiring up the percentage of oxygen that they're getting. What does that mean? Well, the ambient air has 21% oxygen, right, that we normally breathe in. If someone's having difficulty breathing and their oxygen demand is higher, right, we may just need to provide them with a little bit more supplemental oxygen, maybe through a nasal cannula, and we set that to, the book will say 1 to 6 liters, but usually we do about 2 to 4, right? If we go any higher, that's kind of a lot of pressure to go through the nose, maybe thinking about upping it, right? And so we have a nasal cannula, let's say at 4 liters, that's putting 100% oxygen in. Well, it's also mixing with the oxygen that we're breathing, so maybe they're getting about 44% oxygen. That's still much better than that 21% and may be enough to boost their needs, right? And if they need high flow oxygen, but they don't have a ventilation problem, let's say they're in shock, they're showing signs and symptoms of shock. And we talked about what are we going to do to treat for shock? We're going to lay them supine, we're going to keep them warm, high flow oxygen. But they're not having a ventilation issue. They're moving air just fine. They just need a bump in the amount of oxygen that they're getting because maybe half their red blood cells are on the ground because they're bleeding out. So we're just trying to up that amount of oxygen so that we pack as much as we can on each red blood cell, give them a fighting chance, right? So then we would give them the non-rebreather mask, hooked up to that 100% oxygen, and now they're getting, maybe the percentage is much higher, 70, 80% oxygen that they're getting. But if they have any problem with ventilation, if they have a ventilation issue, they're not able to move air on their own. Maybe their respiratory rate's too slow because they're taking because of narcotics that they're on, or because they're breathing just too shallowly. Because maybe they're taunted a brain injury, or maybe it hurts too bad. Then they actually need a BVM. The BVM hooked up to 100% oxygen is going to give them a higher percentage of oxygen, but it's that ventilation that we want, right? And so how do we recognize that? Is we look for the rise and fall of the chest. If we see adequate, if we see good rise and fall of that chest, then it's not a ventilation problem. It's an oxygenation issue. So that's kind of how we can walk our lines down through that. But the other good thing about, or the important thing about ventilation is it's not just getting oxygen in, it's getting CO2 out, right? Remember we talked about CO2 is the byproduct of when the oxygen goes in, the Krebs cycle makes ATP, and now it makes CO2, water, and heat essentially. And then CO2 we can rid that somewhat through our through our kidneys and our urinary system, but a much faster and more efficient way is to just blow it off, right? To outgas it. And it's important that we do that because our body works in a small range of functions, and we don't want our blood to become too acidic and could potentially throw our heart into a lethal dysrhythmia, right? So it's important for our bodies to get that CO2 out, and that happens through ventilation. So on the next one, where it says ventilation and respiration are two separate interdependent functions of the respiratory system. Because always, respirations, right? Think about it. Ventilation is the mechanical movement of air. It doesn't matter what, it doesn't know if it's a carbon monoxide that you're breathing in. Your body is just moving in that air. Respiration is oxygen going onto the red blood cell and CO2 coming off of the red blood cell. It's that fusion happens that I spoke of earlier, right? Your diaphragm will contract, your intercostal muscles will contract, your the thoracic cavity will lower in pressure, and air will come in. That's ventilation. And when that air gets down the trachea, down the carina, bronchi, bronchioles, into the alveoli sacs, and it starts to pass across the alveolar membrane into the pulmonary arterial that are right there. Then that fusion happens where the oxygen CO2 rich is now oxygen rich, CO2 poor, ready to go back through your heart, be circulated to the body. So respiration is the exchange of oxygen, carbon dioxide, and alveoli and tissue. Prevent oxygen cells and move carbon dioxide. Uh, Diffusion of passive gases in which oxygen molecules move from areas of higher concentration of oxygen molecules to areas of lower concentration. Right? That's diffusion. The process that controls breathing. And these in the past, we have these chemoreceptors all over the body are able, in our brain system controlling our breathing. It's information to our body in order to hold to that we need to breathe, right? And we have two components to breathe. We have CO2, and that it's high, and then we have when our oxygen is low. Our body is sensitive to CO2 get too high, it stimulates us to breathe. Then we talk about patients have COPD, chronic obstructive pulmonary disease, sometimes smokers with dyspnea, asthma, chronic bronchitis. They live in areas of constantly high carbon dioxide. So they are some numb to the fact so that they only stay breathe when oxygen level gets low. Springs up because it's important that you put them on low oxygen. You could essentially kill stimulation breathe, right? Because yeah, they have oxygen, they don't have stimulation breathe, so they're not going to be ventilating, moving that air anymore, right? And I mean, hypothetically, well, one, we could start bagging them with a BVM, or once it gets down to a certain point, their bodies, those chemoreceptors aren't going to be getting that oxygen because they're not moving it through ventilation, and then hopefully it would pick up on its own. But that is why we want to be careful when we administer oxygen to these patients with COPD and base it off what their pulse oximetry is, right? How much oxygen is on each red blood cell that's circulating their body, and that's what we get off the pulse oximeter. Another thing to note here is we've been talking predominantly of the external respiration. This is that diffusion that happens at the alveolar sacs for when we get the air into the body and it diffuses across into the pulmonary arteries. There's another location where respiration happens, and that's at every cell of the body, right? So once that red blood cell that had gotten oxygen from the alveoli sacs goes to the pulmonary vein, the left atrium to the left ventricle, and then gets pumped to the rest of the body, and then it goes to each cell, and then that cell is, yeah, you guessed it, it's oxygen poor and carbon dioxide rich, and the red blood cell has has oxygen just ready for it, and the simple diffusion happens again right there, and that's called internal respiration. So it's the same process, just kind of in reverse, and they call it internal respiration, right? Because it's in every cell of the body. The external respiration, but it's still inside our body, right? Yeah, but it's external air that it's diffusing across. So that's where we have these terms: ventilation, respiration. That's also split up into external and internal respiration. So the medulla initiates ventilation cycles stimulated by high carbon dioxide levels. We just spoke about that. The pons has two areas to help augment respirations during emotional and physical stress. So we can vary and control our ventilations on our own, right? And they can also be adjusted due to physical stress, or emotional distress, or as the body sees fit. So ventilation is simple air movement in and out of the lungs. It requires chest rise and fall, right? So when I'm asking you guys, well, how do I know if they have adequate ventilations? Well, look at their chest, right? Do they have adequate rise and fall of the chest? Does it look like they're moving air, right? That's important to note, because when we're trying to decide which oxygen therapy to give somebody, do they need a nasal cannula? Do they need a non-rebreather or bag valve mask ventilations? Well, the big one to decide right off the bat is, do they need ventilatory support, right? Are they moving enough air on their own? Because if they're not, you guessed it, yeah, they're going to need a BVM. If they are, then we need to decide, okay, well, they don't need help ventilatory wise. They're moving enough air. So do they need the high flow oxygen of a non-rebreather, or will a nasal cannula work? So the what we kind of conceptualize this as, this rise and fall of the chest, what's happening is tidal volume. That's the amount of air moved in and out of the lungs during a single breath. And then the residual volume, the gas that remains in the lungs to keep the lungs open. So that'll keep those alveoli stented so that when you take that extra breath again, that it's able to move across. This is important to note. So if somebody is not oxygenating well enough, let's say their respirations are fine too, they're moving air, but their SpO2 is super low. What's going on? Well, they may have some lung disease. There may be some fluid in their lungs there, but what you can do is put them on CPAP, continuum positive air pressure, right? It's essentially the same thing as sleep apnea, the masks that they use. And so that has constant pressure that's pushing on. So even when they're exhaling, this mask is pushing constant pressure to keep those alveoli sacs stented open, so that when they switch from breathing out to breathe in again, the alveoli sacs are already open, so that first air that they're breathing in doesn't have to stent the alveoli sacs open. It just is able to diffuse across easily, right? So it makes it much more efficient. So when we're talking about things like this is somebody that's in respiratory failure, right? Things are not going well for them. And this type of support, it may seem minimal, but it could be enough to help turn them around or help them compensate or maintain. Another one kind of on that is someone maybe putting themselves in the tripod position or the sniffing position, right? Leaning forward with their nose up. What they're essentially doing without realizing it is creating an easier passage for that air to go into their lower airways, right, as they breathe in. And they do it without even realizing it because it's just easier to breathe that way, but they're making it more efficient. They're lining up their airway. And one thing to talk about is somebody that's CO2 retaining or an asthmatic when they have those constriction of those lower airways and they're not able to get that CO2 out. And let's say you don't have a rescue inhaler, they didn't have one with them for whatever reason. We could use pierced lip breathing is a technique that we talked about. And essentially, it's as it sounds. You just have your lips pierced, and then when you breathe in, and then breathe out through those pierced lips, that's keeping some pressure still back in the alveoli sacs to keep them stented open so that when you breathe in again, that it becomes more efficient and it's easier to oxygenate. So that's something that you may be able to coach somebody if you don't have, this equipment or they don't have their rescue inhaler with them. So the next concept that we're going to talk about is dead space, or the portion of the respiratory system that has no alveoli and where little or no oxygen of gas between air and blood occurs. This could be because of that breath stacking or the bad air that they're retaining because they have asthma or COPD and they're not able to exhale all of that air out. They need a longer time to be able to exhale. And then when they inhale the good oxygenated air, it has to travel through that bad air, so they get poorer oxygen exchange. Another reason could be because of lung damage due to the COPD. Other things could cause dead space if they have carbon monoxide. They're in that type of environment, and now their red blood cells they have a stronger affinity to that carbon monoxide than they do oxygen, so they're being bound up with the carbon monoxide, and now they're unable to oxygenate as well. So there's just some causes for dead space and some reasons why you would need to increase their oxygenation or how much oxygen that they're getting. So now let's get back to the tidal volume that we're talking about the how much air they're getting in a single breath in order to calculate the minute volume or minute volume. So if we take the respiratory rate, how much the patient's breathing in a minute, and then times that by the tidal volume, how much they're breathing with each breath, how much volume they're moving, then we get their minute volume, and we can determine how much they're getting, how much volume they're getting over an entire minute. Now, this isn't something that we necessarily calculate with every patient to figure out, but it's more to conceptualize to see the effects of increased respiratory rate and decreased tidal volume. So if the normal respiratory rate is 12 to 20, and normal tidal volume with each breath is about 500 milliliters. That means the normal minute volume with a respiratory rate 12 to 20 is anywhere at 500 milliliters, anywhere from 6,000 to 10,000 milliliters, or 6 liters to 10 liters, right? Now, if we were to increase that respiratory rate, generally people have that shallower respiration. So you can just see that it kind of inversely affects the respiratory rate and the tidal volume. Let's say somebody's breathing at 30 times a minute. Then their tidal volume has to be at least 200 in order to maintain that 6 to 10 liters that the average person's going to need. And that's just at normal oxygen consumption without a higher demand due to increased work of the body, or because they're in a hypotensive state or a hypoperfused state, right? Which most of our patients are going to be in. And then if you bring that respiratory rate even further on the other end, 45 or to 60, that tidal volume is going to be so small, mute, they're not going to hit those numbers. So basically, what this is giving you an idea of is somebody's respiratory rate starts to increase. We need to try to coach them to slow down their breathing, give them confidence that they're getting enough oxygen, and really control that. And so they take bigger, deeper breaths, maybe focus on the exhalation so they're getting that bad air out, kind of counteracting some of that dead space, and that'll improve their minute volume. Otherwise, our next step, and this could be somebody that is having an anxiety attack, right? They're just breathing way too fast, and you can't maintain that for very long. Even just for a few seconds, start to get lightheaded, right? But this patient, we either have to try to coach their breathing, slow that respiratory rate, increase that tidal volume, or we're actually going to have to assist them, right, with a BVM. We may be giving a BVM on a conscious patient that has an increased respiratory rate because they're not getting enough tidal volume, right? And we can't coach them down any other way, or maybe they're obtunded, they're altered, and we're going to assist with every 3 to 5 seconds to deliver an adequate amount of volume, right? And hopefully, inversely, their respiratory rate will start to decrease. They'll be getting enough oxygen. So we want to always evaluate the amount of air being moved with each breath when assessing a patient's respirations. How are we, and see, this is where it can get confusing because it's talking about respirations again, but we're actually kind of visualizing ventilations, right, when we use it in this context. But how do we evaluate that? Again, real quick, we just look at the rise and fall of their chest. If you can see their chest rising and falling and moving air, then they're moving a fair amount of tidal volume, right? And unless their respiratory rate is very decreased on the lower end, 8 and lower, we may not be needing to assist them with bag valve mask ventilations, maybe just supplemental oxygen. So characteristics of normal breathing: normal rate and depth. When we're talking about depth, what are we talking about? We're talking about that tidal volume. How much air are they moving out with each breath? Regular rhythm or pattern of inhalation and exhalation, right? So generally people have just a normal type of pattern. It may be a little bit faster if the person's exerting themselves more, they're trying to get some more oxygen, but there's some clear characteristic of abnormal breathing. One of them indicative of a head trauma would be increasingly bigger breaths with a period of apnea, right? So that would be so that's not a regular rhythm, and that's more indicative of someone having some sort of traumatic brain injury or head trauma. Another one would be the Kussmaul respirations, or if somebody's trying to, this would be somebody possibly having a hyperglycemic episode. They're trying to off-gas that CO2, so their body is telling them, hey, we got way too much CO2. So their emphasis is less on the inhalation, but they're blowing off. They're trying to blow off all that CO2, right? So those are just a couple of examples, and we'll go through some more when we talk about some respiratory emergencies. Um, Another thing we want to listen to the lungs is for clear audible breath sounds on both sides, right? Bilaterally. And we're going to be listening against the skin with the bell of our stethoscope, and we're going to listen at the top and on the bases. Some sounds that we might hear that aren't clear would be rawls, or crackles, right? This kind of sounds like that's underwater. It's got that sort of sound to it, and that is indicative of having fluid in the lungs or pulmonary edema. And the reason why we want to listen to the top and the base is because if this patient is sitting upright, which if they do have pulmonary edema, most likely they will be sitting upright, because that way the fluid will be dependent and fall down to the base of the lungs, so that the lobes at the top don't have that fluid to try to have to move that air through in order to oxygenate. Um, so the fluid's going to sit at the bases there, and you may not hear them at the top, but you may hear them at the bottom. Some other sounds that we might hear would be some expiratory wheezes if somebody has some narrowing of those bronchi or bronchioles because they're an asthmatic, and then we'd hear that and that's the person that's going to be CO2 retaining, breath stacking, and they're going to need a prolonged expiratory phase in order to get that out. Now, the big thing about lung sounds, when we're going to listen to them on scene, well, as soon as you can, right? When you got a good chance to, before you move that patient around, when you got good access to it. And in the beginning, as you get out there, you want to listen to all lung sounds, right? Because how are you going to know what's abnormal unless you hear what's normal, right? And then the thing that can kind of throw people off, somebody could be a severe asthmatic and you're saying, I don't hear any wheezes. Well, they may be so tight, so diminished that no air is really moving through. So you wouldn't even hear their wheezes unless we gave them one of their breathing treatments, albuterol, which dilates those bronchioles, and then you would start to actually hear those wheezes because they're so tight up in the lower airways and their bronchi and bronchioles that you can't even hear any air move through, so you don't hear any wheezes. So we'll be practicing with some lung sounds, but you have to listen to lung sounds a lot in order to kind of get an ear for it. The other one that's kind of a little easier is just to be able to, again, visualize that adequate rise and fall of the chest for tidal volume. So regular rise and fall, movement of both sides. If there's movement only on one side, then that could be indicative of tension pneumothorax, or if this patient's intubated, maybe the tube isn't in the right place and they're not ventilating both sides of the lungs. Movement of the abdomen. This is very important if we're ventilating a patient with a BVM, right? Because if we've already filled up the capacity of the lungs and we're over ventilating, so we're squeezing the bag too much, or we're doing it too quickly, we're not delivering that ventilation over a second so the lungs have time to fill up and expand, then the only other place for that oxygen or that air to go, is to go into the stomach, right? And stomach does not like foreign. It doesn't like blood in it. Doesn't like oxygen or air in it. And when that happens, all the contents of the stomach is going to get mixed around, and it's going to cause that person to vomit. And since we don't have anything in their airway to protect them, that vomit could get aspirated and pushed back into their lungs, cause some infection later on down the line, right? Aspiration pneumonia. So again, when we talk about when we went over the class of the EMS systems, and we want to get them all the way onto the other side and through to a good rehabilitation, and out the other side of this emergency, we got to realize these things that we could do that could actually have a very detrimental effect. Yeah, they weren't breathing for a limited amount of time, so we came in, but we were over ambitious with their oxygenation and ventilation, that we squeezed the bag too aggressively. We caused them to vomit. They aspirated on that vomit, and now they have aspiration pneumonia, and they have a whole other big problem later on down the road. So one of the most important things with ventilation, when we practice in class, is not just getting a good seal on the mask, but so that you learn the appropriate rate and how to squeeze the bag in order to deliver the right ventilations that you're wanting to achieve and the right minute volume. So inadequate breathing patterns in adults, we have labored breathing, right? We talked about this should be a passive thing. the reason why we're breathing, not just to get CO2 out, right, that byproduct of producing that ATP, but getting more oxygen in so that we can make ATP for energy, right, through the Krebs cycle. And if it's taking a lot of effort and energy to do this, then it's defeating the purpose, and people can't maintain, right? And once they fall off and they get too tired, that's when they go into respiratory failure, right? When they're not able to meet the demands. So we need to catch these patients and recognize it early on and give them the support, whether it's through increased oxygenation or through supporting them their ventilatory status through BVM. Muscle retractions, that's a big sign. We talked about the ones at the top of the neck, right? Through the clavicle there. You could also see it sometimes through the ribs and the intercostal muscles. It actually retracting and pulling it through as they're trying to suck air out, right? That's very labor intensive. People can't maintain that for a long time. Skin signs are a great indicator of inadequate breathing. We got pale skin, cyanotic. Cyanotic, what does that mean? The cyanotic means blue, right? So they have the blue skin. They're cool, damp skin. Oftentimes we call cool, pale, diaphoretic, right? That's a sign of shock. Tripod position. So that's the patient that's kind of leaning forward, maybe their hands on their knees, with their nose up in the sniffing position, and they're just, without even knowing it, they're getting their upper airway in alignment to be as efficient as possible. And then agonal gasps. Gasping breaths. This is the one that you really need to be able to recognize, because this is a patient that's not breathing at all, right? It may sound like it. Often that's why they have that gasp that they say, but it's just kind of and oftentimes these patients, they're actually in cardiopulmonary arrest. And so what they need is CPR. So don't be thrown off by a patient with agonal respirations. Something that you won't see with this is any movement of the chest at all, right? And go back to, are they responsive? Not responsive. Let's check for a pulse. Look, listen, and feel. And if you don't feel it, a pulse, then start CPR, right? Don't be thrown off. Oh, I think that they're breathing because they're making this noise, right? So we'll talk some more about that and how to identify it later on. All right, so next up is the circulatory system anatomy. This is a complex arrangement of connected tubes, arteries, arterioles, capillaries, venules, and veins, right? It goes from arteries down to arterioles, down to capillaries, which are the smallest size. That's where the respiration, external and internal, happens, and then back to the venules and veins, back into the venous system. There's the systemic circulation. This is the body's circulation, so everything that once the blood leaves the lower left ventricle, and it brings oxygenated blood to each cell of the body, and then brings it back into the venous system to the right atrium and down to the right ventricle. Then we start in the pulmonary circulation. This goes from the right ventricle getting pumped to the lungs for that blood to be oxygenated again, and then returns back to the heart via the pulmonary vein. Now, some of you may have heard or been under the impression, right, that arteries carry oxygenated blood and veins carry deoxygenated blood. More accurately, it would be arteries are under pressure and flowing away from the heart, and veins are under low pressure and returning back to the heart. This is important to note, so you don't get the pulmonary circulation mixed up. So the right atrium that is delivering deoxygenated blood to the lungs in order to be oxygenated, it's leaving the heart. It's the pulmonary artery. Once it becomes oxygenated and it returns to the left atrium, left side of the heart, it goes through the pulmonary vein. So this is the whole circulation of blood as it comes through or moves through the body. And I know this picture looks a little complicated, but we'll try to break it down for you, and we'll be going over this a lot. When you come out of the class, you should be able to, and especially for the National Registry test, be able to map the blood flow through the entire body, through the main circulatory system and also through the pulmonary circulatory system. So let's start off here with as we get blood that's coming from the superior vena cava, right? Superior means above, so these mean all the veins of the upper neck that are coming down, and then also from the inferior vena cava, see down here. So they come up and they meet and they feed right into that right atrium, right, the top right side of the heart, and the blood will come down through that, through this one-way check valve right here, right? And this valve is the tricuspid valve. Once it goes to the tricuspid valve, we're in the right atrium, or sorry, right ventricle. From the right ventricle, remember this is deoxygenated blood, that's why it's in blue. Deoxygenated blood's going to go from the right ventricle to the right, or to the pulmonary artery through the pulmonic valve right here, and then it's going to go to the right and the left lung, right? In order to have the external respiration occur, and it goes from the arteries to arterioles down to the capillary level in the alveoli sacs right here. That simple diffusion happens, CO2 out, O2 in, right, diffuses, and now we have oxygenated blood. The oxygen's being carried on the red blood cells, erythrocytes, and that's able to return to the heart through, the vein, right? The pulmonary vein returns to the right or the left atrium. The left atrium then goes through the mitral valve into the left ventricle. From the left ventricle, it goes up into through the aortic valve, through the aorta. Now this is the major blood vessel, and one of the major blood vessels of the body, and also kind of what the heart is hanging on, right? The aorta right there. And then we're going to go from the major arteries of the body, either inferior or superior up to the head. And then you see these two pictures at the top and bottom here. This isn't just happening twice. This is happening in every cell of the body, all tissue cells, right? The lower body representation here and the upper body. And again, it goes from arteries to arterioles at the capillary level. This is where the internal respiration happens. The O2 goes into the cell, CO2, the byproduct of that, the creation of the ATP, goes back into the blood, and then it returns into the venous system in order for it to happen again, right? So this is happening all the time throughout your body. And you're going to need to be able to map this out, and in class I'll show you guys a way to kind of separate it so you don't have to think of it this kind of confusing, right? So we'll be going over that, but definitely review it whenever you get a chance, just one piece at a time. So the heart is a hollow muscular organ that is approximately the size of an adult's clenched fist, made of specialized cardiac muscles. We talked about that earlier. It's one of the three specialized muscles. Works as two paired pumps, the septum divided right and left sides. Each side is divided into the atrium, which are the upper chambers, and the ventricles, which are the lower chambers. You got to find some way to kind of keep these things separate and to kind of remember them. I always just think of A's first, atrium, so the upper chambers, and then down to the ventricles. Circulation. The heart receives its blood from the aorta. The right side receives deoxygenated blood from the veins. The left side receives oxygenated blood from the lungs. So this is just showing the pathway that we just went over, right? Got the coming from the superior and inferior vena cava, going into the right atrium, through the tricuspid valve, into the right ventricle, to the pulmonic valve, into the pulmonary arteries, and then it goes to become oxygenated. It comes back through the pulmonary veins, through the left atrium, down through the mitral valve, into the left ventricle, and then it goes through the aortic valve to be pumped to the rest of the body. So heart rate, normal resting heart rate is 60 to 100 beats a minute. That's just an average, right? The stroke volume is the amount of blood moved by one beat. Cardiac output is the amount of blood moved in 1 minute. So how do we factor the cardiac output? Well, it's the heart rate times the stroke volume, right? So does this sound familiar? It's a lot to do with the same as finding out the minute volume for our timesing our tidal volume times our respirations to find out our minute volume. And the interesting thing is our the volume of air that we get in is about 6 to 10 liters, and so is our cardiac output on average, about 6 to 10 liters, right? Um, so it's a kind of an interesting factoid there. So next we're going to talk about the electrical conduction system of the heart. We had brought up about how there's smooth muscles of the heart and they're specialized, right? And this electrical conduction system causes a smooth, coordinated contraction of the heart that produces the pumping action. The reason why our heart is pumping in the coordinated fashion is because of this electrical conduction system. This impulse starts in the sinoarterial node, the SA node, um, which is located in near the right atrium, and intrinsically sends a signal once every 60, so that it will send a signal 60 to 80 times a minute, right? Because that's the average normal heart rate, and then that impulse will travel down to the NA node, and then it will actually pause near the bundle of His as it goes through then the Purkinje fibers and wraps around the whole ventricles. And it's a coordinated process that we'll get to when we start talking about the cardiovascular system more and more cardiovascular emergencies. Because the problem is what if something affects this electrical conduction system, right? So that's these muscles sending the impulse, but if there's not appropriate blood flow to give these muscles the oxygen that they need for them to perform work, for these muscles to work, not just for their pumping action, but also for this electrical activity, then that's when people get put into arrhythmias and problems occur, right? So, arteries carry blood from the heart to all the body's tissue. The aorta branches into the coronary arteries, which feed the actual heart itself. They go up to the carotid arteries, which will feed the brain and give it the rich blood supply it demands. The hepatic arteries of the liver, right? It needs a rich blood supply. It filters blood, very vascular. And the renal arteries of the kidneys needs constant supply of blood, and then the mesenteric arteries as well, the digestive system. So the pulmonary arteries carries oxygen poor blood to the lungs. Arteries branch into smaller arteries and then into arterioles. Arterioles branch into a series of increasingly smaller vessels until they connect to the capillaries. Capillaries become just a single cell, right? And that's where that simple diffusion happens on that very, very tiny cellular level. A pulse is palpated or felt most easily in the neck on the carotid artery. The wrist is also felt easier, but at the same time, that pulse that we feel on the wrist, if a person is hypotensive, has low blood pressure, or in a shocky state, the body tries to compensate by shunting blood away from their periphery more to their core. So that's maybe why you don't feel a pulse when you feel for their radial pulse on their wrist. The groin is another central pulse, and you can feel that the femoral artery right there, but it may be difficult for you to locate. The quickest and easiest is the carotid artery right on the neck. Something to note is never, if you have multiple people feeling for to try to assess to see if somebody has a pulse, if they're unresponsive, that's okay, and it's a great thing, but you cannot have people feeling, two people feeling the carotid artery, right? Because if we are, when you feel for a pulse, you're kind of occluding the artery and pushing it against a bone or a soft or a harder surface in the body. And if you're occluding both sides of the carotid artery, you're preventing the blood from perfusing the brain, right? So would be good to have one person checking a carotid artery, and then you can have somebody checking the femoral artery on both sides. Because if you block that perfusion to the legs temporarily, it's not as big of a deal as blocking the perfusion to the brain. So this pulse that we're feeling is actually the force generated in systole when the heart is pumping, right? And it pumps and it sends a pressure wave from the left ventricle as it moves through the artery, and that's actually what we're feeling when we feel a pulse. This just shows you some locations of major landmarks for arteries or veins, and we'll discuss the major ones that you need to know in class. So capillaries connect arterioles to venules. Fine end divisions of arterial system allow contact between blood and cells, right? This is where the diffusion happens. This is where the external and internal respirations happen. Veins, they return oxygenated, depleted blood to the heart. The superior vena cava carries blood returning from the head, neck, and shoulders and upper extremities. The inferior vena cava carries blood from the abdomen, pelvis, and lower extremities. They join at that right atrium. The spleen is a solid organ located under the rib cage. It filters blood, particularly susceptible to injury from blunt trauma. Can lead to severe internal bleeding. The spleen, sometimes people may have had it removed. Might be something to ask about. But yeah, in the case of blunt trauma, that's going to be one of the organs that we're very concerned about. Solid organs, they will actually lacerate and bleed out, causing a lot of internal bleeding because this is the job of it's to filter blood, so it's very vascular. Blood composition. We has plasma, that's the kind of liquid, the kind of everything else in the blood. It gives it volume, bulks it up so that it has volume in order to be able to, because it takes pressure to move through these giant lanes and tubes, lumens of capillaries in order to perfuse the tissue at the other end. Red blood cells have erythrocytes. Remember from medical terminology, that's a red blood cell, right? Erythro. And then leuco, white, right, for white blood cells. So red blood cells are, have the oxygen comparing the capability to carry the oxygen, right? The oxygen binds to the red blood cells. That's what when we use a pulse oximeter, we're looking at one red blood cell, and we're seeing how much percent full it is of oxygen, and then we're kind of assuming, well, it got oxygenated at the same time as all the other blood around it, so that it's going to be close to the same, right? So it gets us in the ballpark of how much of all of that blood in the body at that time, percentage of it is being held by oxygen. White blood cells or leukocytes are used to fight infection. They got a cascade system that we'll kind of talk about later. And then the platelets, they're what can they start to allow for clotting factors. So the circulatory system physiology, blood pressure, pressure that blood exerts against the walls of the artery. Systole, when the left ventricle of the heart contracts, it pumps blood from the ventricle and the aorta. Diastole, when the muscle of the ventricle relaxes, the ventricle fills with blood. So the systolic pressures is always going to be higher than the diastolic, right? Because the pressure wave when the heart is beating or pumping, when the left ventricle is contracting and squeezing, it sends that pressure wave we talked about as a pulse, but it's also adding the pressure in that system and pressurizing it. And really all a blood pressure cuff is doing, if we place the blood pressure cuff on and then we pump it up, usually we're going to pump it up past where we think the systolic pressure is going to be for the patient, and then we watch the dial as it starts to come down, and then when we first hear that noise and that we auscultate that noise, that is the blood as it's able to pass the pressure that's around the cuff. So at that point in time, the pressure in the blood or in the arterial system is higher than that pressure that's on the blood pressure cuff that is around the arm. So that's how we know that that's the systolic pressure. And then we are going to keep on watching the dial as it goes down as we let the pressure come out of the cuff. And then when we're no longer hear that pulsating, that beat, we're going to think about right when it dropped, the last time that we heard it, and that's going to be our diastolic pressure. That's just the floating average pressure in the arterial system. And for most of the time, as the EMT level, we direct a lot of stuff to the systolic blood pressure, right? But really, as we kind of get a little more advanced, the diastolic is important. Well, the mean arterial pressure is actually the systolic times or plus twice the diastolic divided by 3. And that gives us the average arterial pressure altogether, right? And this number is really important because it's not when the heart is pumping in systole, it's actually in diastole that those coronary arteries are going to get perfused, right? That the arteries of the heart are going to get the blood that it needs for those muscles to perform work, right? So, but most of the time, right, when we're talking about the whether we're considering somebody to go on the path of hypotensive, um, or whether we can help administer them with nitro or place them on CPAP. It's going to be based off that systolic pressure, that higher number. So blood pressure reading, systolic pressure, high point of the wave, diastolic is the low point. So normal circulation in adults, uh, automatically adjusted and controlled. Perfusion, circulation of blood in organ or tissue in adequate amounts to meet the needs of a cell, right? So if that's the definition of perfusion, hypoperfusion is there is inadequate amount of blood for the organ or tissue, right, to survive. So by definition, hypoperfusion is shock, right? When we're thinking of a patient being in shock, their body is no longer able to adequately supply that tissue or those organs with an amount of blood or oxygenation that it needs. So blood enters an organ and tissue through arteries. Blood leaves organs and tissue through veins. And as you can see here, right, it goes arteries, arterioles, down to the capillary level. And then what's going on here? Well, if we're talking about in the organ tissue, that's the internal respiration, that diffusion, right? Oxygen offloads into the cell, and then carbon dioxide, waste product, goes back onto the blood, and now it goes back into the venules and into the veins to go back to the heart in order to get pumped to the lungs so that it can blow off the CO2 and become oxygenated again, right? So inadequate circulation in adults. The system can adjust to small blood loss. Vessels can constrict, right? So we got a small amount of blood loss, so we're losing some volume, pressure is going to drop. Let's constrict these blood vessels in order to help boost the pressure so that we're getting the blood to these organs, right? But we still have to compensate for, we have less blood, so less red blood cells. So maybe we'll breathe faster, we'll have the heart beat harder and stronger, so that the red blood cells that we do have, maybe we'll get a little bit extra oxygen on board them, and we'll just circulate it faster, right? Um, with large loss, adjustment fails and the patient goes into shock, right? So that's when we talk about shock, we have the different phases: compensated shock and decompensated shock. So compensated shock would be that small amount of blood loss, right? The heart is beating faster, blood vessels are constricting, the patient is breathing heavier, they're tachypnic, they're tachycardic, they're vasoconstricted, and they're compensating, right? They may maintain a normal blood pressure. And then once they get into decompensated shock, their body's ability to compensate is failing. So their heart is going to start to decrease. They're still going to be tachypnic. They may even go bradycardic, right? That's a real ominous sign because now their heart isn't getting oxygenated well enough to keep up, and they're going to start to go hypotensive. And so that's when we're in shock. Really, so we got to try to help the patient that's in shock by giving them supportive care, right? We lay them supine, we talked about, so that they can perfuse their brain easier, and the rest of their body doesn't have to fight. It's already going to vasoconstrict, but it doesn't have to try to fight gravity. We're going to keep them warm. We'll talk about later how that helps out with coagulation, if they're a bleed that their body is trying to stop. And also most systems, they just do much better when they're in this warm state. and then we're going to give them high flow oxygen. Now, if they have a problem with ventilation, inadequate rise and fall, we're also going to ventilate for them with a BVM. But most of the time, it may just be giving them supplemental oxygen. If we're talking high flow oxygen, that means by definition we're going to go non-rebreather at least 10 liters per minute. And then that way, the red blood cells that they do have, we're just packing them full of oxygen to try to support the patient, really. In everything that we do, we're not turning things around for the patient. We're supporting them and helping their own body and the things that they've got to maintain and support themselves. So functions of blood. Perfusion. What is perfusion? Well, perfusion is getting the blood to a cell in order to provide that cell with oxygen and in order to get rid of the waste products from that cell, predominantly CO2. So transporting oxygen, transporting carbon dioxide, transporting other waste and nutrients, and also that clotting, right? That ability for coagulation. So if there is a bleed or a break in the system, the artery, the vessel, hopefully it's going to start going to work and to block that up so that it can still work in order to perfuse the cells and the organs of the body. So nervous system, control of the cardiovascular system. Sympathetic nervous system is responsible for fight or flight response, right? So when we talk about this, we're going to have the sympathetic nervous system and the parasympathetic nervous system. The sympathetic being the fight or flight, parasympathetic being feed or breed type of stuff, right? Longer term. And so when you think of that fight or flight, instant, I need it now, it's a shorter word, sympathetic, right? Versus the parasympathetic. So this sympathetic fight or flight response sends commands to the adrenal glands, epinephrine, also known as adrenaline, and norepinephrine. Noradrenaline are secreted to stimulate heart and blood vessels, right? They're going to stimulate the heart in order to beat stronger and faster, so with more force and faster, and then those blood vessels to be able to constrict so that raise that blood pressure. So blood vessels have alpha adrenergic receptors. The heart and lungs have beta adrenergic receptors. So we have beta 1 and beta 2. Alpha 1 is responsible for those the blood vessels of the body, right? So constricting those blood vessels. And then the beta 1 is responsible for the heart to increase its contractility, so its strength of force of contraction, and also the rate of contraction. And then the beta 2 was responsible for the lungs to vasodilate, right? That's when you get that adrenaline, fight or flight, you get vasoconstriction, you have beta 1 stimulating to beat faster, stronger. Beta 2 is dilating, so you're getting your lower airways and your bronchioles are dilated to get more oxygen to support the demand of the body, right? These are all, this is that epidump we were talking about. The parasympathetic nervous system is the exact opposite. So one thing that's interesting, the more you start to learn about the body, anything that they have set in place to act one way, there's generally a whole system to act in response of the other way, right? To balance it out. The body works in homeostasis, right? This place in between. And sometimes, yeah, it needs, your body needs that fight or flight, that dump, but other times it needs to calm down, cool down, things need to happen at a different pace. So that's where we have the parasympathetic nervous system, and it has effects on the cardiovascular system, addresses actions that do not require immediate response, right? So the slower ones. That's why we talk about the feed and breed, right? It's just as important, but these are longer, usually longer, bigger changes than that the fight or flight type of change. So the nervous system, anatomy, and physiology. The nervous system is perhaps the most complex organ in the body. It's divided into two main portions, the central nervous system and the peripheral nervous system. And one thing where we really check, right, we check CSMs, right? Circulation, sensation, and motor function. Why are we checking that? We check it with anybody that we suspect a potential spinal cord injury, or type of neurodeficits, or we think there's a problem possibly with the central nervous system, being the brain or the spinal cord, or the peripheral nervous system with those nerves, right? And to make sure that they're communicating to each other, because if someone has a spinal cord injury, then that communication, that line's severed, right? So we're checking for that circulation, the cap refill of the finger. If we push down, we get a good cap refill. We know that it's circulating there. Sensation, they have the feeling, and motor function, they're able to move. So there's just some ways that we're checking out the communication between the central nervous system and the peripheral nerve. So the central nervous system is the brain. It's the controlling organ of the body, right? It's the computer. Subdivisions is the cerebrum. We have our kind of our personality over there, and then we have the cerebellum, and then down to the most basic brainstem that it tells our body that we need to breathe, or has all those autonomic responses, right? So there's different things handled in different areas, portions of the brain. The spinal cord, extension of the brainstem, transmits messages between the brain and the body. And the interesting thing between the central nervous system and then the peripheral nervous system that we'll go on to next, is their ability to communicate to each other, right? So we get the peripheral nervous system divided into two main portions: the somatic nervous system and the autonomic nervous system. The somatic nervous system transmits signals from the brain to voluntary muscle, right? So it says that I can pick up this pen, right? You send a signal from your brain to these voluntary muscles, and it allows me to do that movement. My brain is talking to those muscles. I know how to control it, right? And then we have the autonomic nervous system. This is that involuntary action, split into two areas: the sympathetic nervous system, the fight or flight; the parasympathetic system, which slows the body. So we have peripheral nerves. The sensory nerves carry information from the central nervous system, um, from the body to the central nervous system, right? This tells us, ooh, that's hot, and that sends that information to our brain through our sensory nerves from the body to the central nervous system. And then we have the motor nerves, carry information from central nervous system to the muscles that allow us to pick up that pen. Now the interesting thing is that reflex arc that we have, right? That's the reason why if you're not paying attention and your hand touches against the stove or something hot, and your hand automatically moves away, right? You didn't think about that. It did send sensory nerves so the sensory nerves sent information to your spinal cord. As soon as that information got to your spinal cord, you had a reflex that said, this is hot, don't touch it, and pull it away. At the same time, that information continued up to the brain to say, hey, this is hot, so you know what's going on, right? So that's a reflex arc. But at the same way, if you can voluntarily hold your hand there on that stove, even though it's hot, because you're voluntarily going against your natural stimulus to recognize that reflex arc. But it's kind of interesting how that works. So that reflex arc means that those sensory nerves can actually send information directly to your spine, and as it's still continuing up to your central nervous system in your brain, but it's also going right back down to your motor nerves, so it carries off that action to remove that hand immediately, right? So sort of a self-preservation thing. So the integumentary system, and this is a word you guys probably, try to remember to, we're used to saying skin, obviously not integumentary system, but you'll see it on on your guys' assessment skill sheets, and it'll come up again. So just try to remember integumentary. That we're talking about skin, right? There's two layers: the epidermis, that's that superficial layer, right? Epi on top of the dermis. Dermis is that deeper layer. And then you got the subcutaneous tissue that lies beneath the skin. This is where the fat is that insulates and serves as an energy reservoir, right? So we can have fat, we can have energy stores, keeps us insulated, keeps us warm. Um, we have sweat glands in there, and then there's different layers of the as we'll see here, right? So the epidermis is actually kind of dead, flaky skin that's starting to slough off. That's why you see it's not being perfused here, where these little bundles of capillaries are kind of starting. That's why you can kind of scratch your top epidermis, and it just kind of flakes away, right? But the hairs will stick out from that layer, the pores will stick out from that layer. And then once we start to get into the dermis, that's when we get the actual muscles that can control the hair in order to make it stand erect to try to warm us up. There's also some sensory nerves that are located in here. Our sweat glands are located in there. As you see, blood vessels. Um, and then as the lower we got the subcutaneous fat. Kind of looks yellowish like this. So if you get a real deep cut, this kind of will tell you um, how deep are we, right? So if we're into just the epidermis, superficial, right? If we're going past the dermis here, we're starting to get considered deep, and then it goes to the fascia, down to the muscle, right? That's real deep. So the integumentary system physiology. The skin is the largest single organ in the body. It's considered an organ. Three major functions. It protects the body in the environment. It helps regulate body temperature and transmits information from the environment to the brain with those sensory nerves. So the skin is really important, but at the same time, in your body's self-preservation, if it starts going into shock or a hypoperfused state where it has to choose, the skin is able to go longer periods of time without oxygenation. So it'll shunt blood away more towards your your core and away from your periphery. Next up, we have the digestive system. Anatomy. Digestion, the process of food that nourishes the cell. Processing. Abdomen, the second major body cavity, contains major organs of digestion and excretion, organized into four quadrants: right upper quadrant, right lower quadrant, left upper quadrant, left lower quadrant. So here we go. It's important for you guys to start to imagine what organs lie within what quadrants, right? So your gallbladder is going to be your right upper quadrant, where your spleen is your left lower quadrant. We talked before about how in trauma, that's a big one that we're concerned about. The liver is predominantly in your right upper quadrant, but does extend to your left upper quadrant. And then in the different intestines, right, you have the descending, transverse, ascending for your large intestines and your small intestines. The appendix is going to be on your right lower quadrant. So a lot of these are going to be, may see on test questions for where pain is associated. Well, what organ is at that location? We don't diagnose, but it should be on our differential diagnosis, things that could be wrong with them. So part of the digestive system also has the mouth, the lips, right? Cheeks, gums, definitely the teeth, the tongue, salivary glands. That's when the digestion actually starts, right? We have enzymes that are released in the mouth that help to start to break down food. The action of chewing is breaking food down into smaller pieces so that when it gets to the stomach, it's easier to start to be broken down to be absorbed. So the oral pharynx, esophagus, stomach, pancreas, all parts of this. Pancreas helps make the insulin for our body in order to use the glucose or the sugars from the food that we get in order for it to enter the cell. The insulin is the key to get that glucose inside of the cell. Without insulin, it doesn't matter how much sugar is floating around in the system. Your cell is going to be hypoglycemic. It's going to be low sugar. It's going to be deprived. It's not going to be able to function properly, right? And we'll go over that more. It's considered part of the endocrine system as well. So the liver, bile ducts, small intestines, large intestines, and then your appendix and rectum, right? So your whole gastrointestinal system, GI system, is essentially the mouth to the anus, right? Everything that lies in between. So enzymes are added to the food by salivary glands. We talked about before: the stomach, the liver, pancreas, small intestines. Food is converted into basic sugars, fatty acids, and amino acids that are further processed by the liver, circulated via the blood throughout the body. So the digestive system is complex and has a lot of organs that are involved with it. So questions about diet, um, whether it be their eating habits, any changes in that, bowel movements, are very important. So next up we have the lymphatic system. Elements of the lymphatic system are the spleen, the lymph nodes that actually um, produce the lymph vessels that help carry that lymph, the thymus gland, and there are other components as well. So the lymphatic system supports the circulatory system and its immune system. For our resources in what we're going to kind of be interested about the lymphatic system is that its immune system, um, the, the support of that in the circulatory system. Lymph is a thin straw-colored fluid that carries oxygen and nutrients to cells and waste products away. It also helps rid the body of toxins and other harmful materials. So the endocrine system, anatomy and physiology. Um, the endocrine system, it's complex message and control system, integrates many body functions. Hormones are released directly into the bloodstream: epinephrine, norepinephrine, insulin. That's a big one that we're going to be, concerned about when we talk about problems with the endocrine system. The big one is going to be diabetes, hyperglycemia. The brain controls the release of hormones. Excess or deficiencies in hormones can cause disease. We got hypothyroidism, hyperthyroidism. There's going to be people with um, different diseases associated with the failures of their endocrine system. But the big one, that affects, what's going to kill you or potentially could kill you right now, and that'll definitely be dealing with hypoglycemia. Um, and so when we think endocrine system, really be thinking of that. Diabetes, really important. We'll get into that later. The urinary system, anatomy and physiology, controls the discharge of certain waste materials filtered from the blood by the kidneys. Um, the controls fluid balance in the body, filters and eliminates waste, controls pH balance. So super important, right? Our bodies produce like we or work best like we discussed at this homeostasis and the certain levels with certain pH. So not unlike how our respiratory system helps maintain that by blowing off CO2. Our urinary system, our kidneys do help. Not only do they filter waste, they help control pH. They also can decide whether we're going to retain fluid or get rid of fluid to try to help with our circulation of our blood. So the kidneys, and then the ureter, and then the urinary bladder, and then down through the urethra, and then if we're talking about males, through the penis and the external opening, right? And um, some effects that you may have here would be, kidney stones. People that are on dialysis, that their kidneys don't work, they can't filter. That's why they need to constantly go on dialysis to have their blood filtered out. It's so important, because if you don't have your kidneys, you can't survive, right? The blood needs to be filtered out, and the kidneys are necessary to do that. If not, then the patient's going to be on dialysis, and we'll talk about that with some special um, circumstances for different patients kind of later on. So the genital system, anatomy and physiology, controls reproductive process. Male system consists of the testicles, the epididymis, the vas deferentia, prostate gland, seminal vesicles, and the penis. Um, Here's a diagram of it. We'll go over with the reproductive system, because we also got to remember, with that kind of life and limb, even though some emergencies may not be life-threatening, if they can affect essentially the male's ability to reproduce. like kind of a testicular torsion, if there's a twisting and we're cutting off blood supply to the testes, right? These are true emergencies just based on that fact alone. Female system consists of ovaries, fallopian tubes, your the cervix, the vagina, and the uterus. So, unlike kind of how we were talking about, may not be a life-threatening emergency for a lot of potential problems with the male reproductive system, very different with the female reproductive system. So the big one and the reason why we talk about everyone of childbearing age uh, that's female, we need to ask them questions about their sexual activity to see if there's any chance that they could be pregnant, would be because of an ectopic pregnancy. An ectopic pregnancy, essentially by definition, means anywhere other than the uterus that an egg was fertilized, right, and developing. But the part that concerns us the most is when it happens in the fallopian tubes. So the ovary produces an egg, an ovum, and these finger-like projections kind of take it up here. And the normal route is to go through the fallopian tubes and sit in the uterus and wait to hopefully be fertilized. Well, if it gets stuck here in the fallopian tubes and gets fertilized there, this is very small, right, location. So as that egg gets larger and develops, it will actually rupture that fallopian tube and cause massive bleeding, massive pain, and is extremely life-threatening. So life support chain. All cells in the body require oxygen, nutrients, and removal of waste, right? So the blood is what helps facilitate that, right? It brings oxygen, removes waste, and it also is able to help bring nutrients. Um, in, in interference occurs, cells become damaged and die. They become necrotic. So, the life support chain. Cells use oxygen to turn nutrients into chemical energy through metabolism. The adenosine triphosphate, ATP, is used to store the energy. Aerobic metabolism uses oxygen. Cells switch to anaerobic metabolism when oxygen is limited. Lactated acid is damaging waste product. So the best way that I can kind of conceptualize or think about this is, if let's imagine for a second that we have a few pallets of wood that are burning. They're burning really well, right? Imagine a bonfire. And if we think of aerobic metabolism and the instance that we have oxygen, it's like taking another pellet and throwing it on that fire, right? It's producing energy, producing ATP, really efficient. Now, if we don't have oxygen, we can go to the anaerobic metabolism, or if oxygen is limited, and that's kind of like throwing a tire onto this fire. So we're going to produce heat, we're going to get ATP out of it, but then all that black smoke that accumulates, that's that lactic acid, that's that waste product, and our body has to rid of that, right? So it's not as efficient, and there's a lot more of a waste product. So if we could prefer, we'd much rather use the presence of oxygen, have aerobic metabolism. So movement of oxygen, waste, and nutrients occurs by diffusion. pH is critical diffusion, measured by acidity and alkalinity. The lower the number, the more acidic; the higher the number, the more alkaline. The body expends a large amount of energy to maintain this normal pH, right? It's super important for the body to maintain the pH. The same receptors that measure, CO2, oxygen, they're maintaining this pH of the body to try to maintain this homeostasis so that all these cells' reactions in the body are able to be maintained. So, the study of the functional changes that occur when body reacts to disease, pathophysiology, right? What does the body do? Um, uh, what changes are made when the body's reacting to different disease processes? Respiratory compromise is the inability of the body to move gas effectively. Hypoxia, right? Low oxygen. Hypercarbia. So this is a high level of CO2 or a low level of oxygen. Both can be really bad for the body. We talked about how important it is to maintain that pH. Well, we could even be getting plenty of oxygen in, but we're over ventilating. Now we're in a hypercarbia state, right? If someone's hyperventilating, they're breathing too much. They have too much oxygen. Um, so factors that impair ventilation: blocked airway, right? Whether it be a foreign body airway obstruction or the patient's own tongue. Um, About 70% of the time, when a patient is altered or unresponsive, uh, it's going to be their own tongue that's going to be that airway obstruction. That's why we try to utilize an OPA or an NPA to stent that space open, to move that tongue out of the way so that we have a space for the air to move through. Impairment of muscles of breathing, airway obstructed physiologically, asthma, and then other factors. Factors that impair respiration: change in atmosphere, high altitude, right? The same percentage of oxygen is at sea level than it is up here or even higher altitude, but those molecules are further apart. So it's more difficult for your body to get the amount of oxygen that it needs. Impair movement of gas across the cellular membrane. The VQ ratio. So V is ventilation, Q is perfusion. I don't know why Q is perfusion, but you just got to remember that. So how much gas is being moved effectively through the lungs? Ventilation. How much blood is flowing around the alveoli where perfusion occurs? That's that perfusion element. Mismatch occurs when one variable is abnormal. So if you don't have an issue with ventilating, then maybe it's an issue with perfusion, right? What if they have a pulmonary embolism? So that's a PE, right? So pulmonary lung embolism. It's a clot that's formed in there. So it's actually blocking the blood supply to the alveoli. So you're getting plenty of oxygen or plenty of air to that site, and oxygen's in that air, but it's not able to diffuse onto the blood because the blood is getting blocked in that section of the lung, right? And depending on how large it is how detrimental that's going to be to the patient. Um, so effects of respiratory compromise on the body: oxygen levels fall and carbon dioxide levels rise. Respiratory rates increase to try to compensate for this. Blood becomes more acidic. The brain then sends commands to the body to breathe, right? All in an attempt to get rid of the CO2 because it's too acidic. So, yes, it's important that our body needs oxygen, right? But what if we don't have oxygen? What's our body going to be able to do? Well, it can perform aerobic metabolism, but then it's going to become more acidic and more acidic. And your body, once it becomes too acidic, that's when you can have a lethal arrhythmia. Shock occurs when organs and tissue do not receive enough oxygen. Impaired oxygen delivery causes cellular hypoxia, categorized into several types depending on the cause. So we'll go and spend a lot of time talking about shock later on. But if your body is not receiving enough oxygen, then you have hypoxia. Now, if you're hypoperfused, it could be because you don't have enough blood to carry the oxygen, or there's not enough oxygen in the blood. Effects of shock on the body: the level of oxygen supplied to the tissue falls, cells engage in anaerobic metabolism. Severe metabolic acidosis ensues. Baroreceptors initiate the release of epinephrine and norepinephrine. The heart rate increases. Interstitial fluid moves into the capillaries, and you get that fluid shift. Um, Impairment of cellular metabolism. This results in the inability to properly use oxygen and glucose at the cellular level. Cells create energy through anaerobic metabolism. This can result in metabolic acidosis. It's not efficient, not sustainable. Brain cells can not use alternative fuels. They need a steady supply of glucose, right? That's why hypoglycemia, low blood glucose levels, is such a dangerous thing because your brain cannot function. So what happens when your brain stops functioning? Well, you stop breathing, right? And then once you stop breathing, your heart is going to eventually give out because you're not getting the oxygen that your heart needs and you're not getting rid of that CO2. So cellular injury may become irreversible. That means no matter what you do to restore it, to bring it back, it's still the damage has been done, right? And if depending on what cells have been involved, then it may have inevitably a fatal outcome for the patient. So now let's go into the review. Which of the following are found in the retroperitoneal space? Is it the liver, the spleen, kidneys, or the stomach? So C, the kidneys. They lie in the retroperitoneal space, the space behind the abdominal cavity. The spleen, liver, and stomach are all located within the anterior true abdomen. The cartilaginous tip of the sternum is called the costal arch, manubrium, angulus, xiphoid process. D, the xiphoid process. Form the lower part of the sternum, is made up of cartilage and relative to other parts of the sternum. The manubrium, the angulus is soft to palpation. And remember that xiphoid process also is directly over the diaphragm, so we want to try to avoid that when we're doing compressions. A person with bilateral femur fractures has fractured one of his or her femurs, fractured both of his or her femurs, one femur fracture in two places, fractured the lateral aspect of the femur. B. The term bilateral refers to both sides of the body with reference to the midline. Therefore, bilateral femur fracture would indicate that both femurs are fractured. The most prominent landmark on the anterior surface of the neck is the mastoid process, cricoid cartilage, thyroid cartilage, cricothyroid membrane. The thyroid cartilage, commonly referred to as the Adam's apple, is the most prominent landmark on the anterior or front surface of the neck. The cricoid cartilage is located directly inferior or below the thyroid cartilage. It is less prominent landmark. Insulin is produced in the liver, pancreas, thyroid gland, or adrenal glands. The pancreas is a solid organ that produces both insulin and digestive juices. Insulin is produced in the islets of the Langerhans, which are part of the pancreas. Blank connects muscles to bones. Ligaments, cartilage, tendons, or joints. Tendons connect muscle to bones. Ligaments connect bone to bone. Cartilage is smooth connective tissue covering the ends of bones at mobile joints. Joints consist of the ends of the bones and the surrounding connecting and supporting tissues. The normal resting adult rate is 50 to 70 beats a minute, 60 to 100 beats a minute, 80 to 110 beats a minute, 110 to 120 beats a minute. B. The normal resting heart rate for an adult is 60 to 100 beats a minute. Bradycardia exists when the adult heart rate is less than 60 beats a minute, and tachycardia exists when it is greater than 100 beats a minute. The left atrium of the heart receives blank blood from the blank, oxygenated from the lungs, deoxygenated from the body, oxygenated from the body, deoxygenated from the lungs? A. The left atrium receives oxygenated blood from the lungs via the pulmonary veins. The right atrium receives deoxygenated blood from the body via the vena cava. The largest part of the brain is the cerebrum, brainstem, cerebellum, foramen magnum. A. The three major parts of the brain are the cerebrum, the brainstem, the cerebellum. The largest part of the brain, the cerebrum, which is sometimes called the gray matter, the cerebellum is sometimes called the athlete's brain, is the smallest part of the brain. The brainstem is responsible for vital functions such as heartbeat, breathing, and blood pressure. The foramen magnum is a large opening at the base of the skull through which the spinal cord passes. Which of the following statements about red blood cells is false? They contain iron, they carry oxygen, they help to fight infection, they give color to the blood. C. The hemoglobin molecules in red blood cells contain iron, give color to the blood, and carry oxygen. White blood cells play a role in helping the body to fight infection. This concludes Chapter 6, The Human Body. Please email me with any questions, comments, or concerns about this lecture at matt.falkowski@hotmail.com. And the password for the associated quiz will be tendons. Thank you.